So like I mentioned, I'll first focus more on EGFR and ALK, and then we'll talk a little bit about other resistant mechanisms for other subtypes. So talking about EGFR, I think really is the poster child in terms of us understanding the mechanisms of resistance. So as you see here, this is a very elegant study by Dr. Leonardi and colleagues, where they actually looked at mechanisms of resistance to osimertinib. And as you see, there is a variety of different mechanisms of resistance, one of them being actual mutations at the drug binding site, like C797 mutation can lead to impairment of binding of osimertinib, and thus confers resistance to osimertinib as a resistance mutation here. The other particular mechanisms are MET amplification. So this is like the bypass signaling category of mechanism of resistance that I mentioned earlier, which occurs in about 7 to 15% of patients with EGFR resistance to osimertinib. And then, it's important to note that, for about half of these particular resistance, we don't really know what the resistance mechanism is for the tumor. And so there's obviously a lot more work needs to be done in this space. There is actually work being done in identifying trends and potential categories that we should be looking out for. So this this study presented by Dr. Ramalingam at the recently concluded World Lung Meeting actually took about 1,300 patients who had experienced progression on first-line osimertinib, and through really elegant liquid biopsy studies demonstrated that perhaps if the progression is occurring within the first year, perhaps bypass signaling pathways like MET amplification may be more important and more prevalent. And if the progression occurs, post a year, then perhaps on-target resistance mechanisms such as the EGFR C797 may be more prevalent in these cases. So this is kind of trying to identify some trends so that we can tailor our treatments accordingly. So when we talk about acquired resistance to osimertinib, again, kind of thinking through those categories. So if we have on-target resistance, I'm going to be talking about, different strategies, including 4th generation EGFR TKIs, clinical trials, and perhaps, going back to 1st and 2nd generation EGFR TKIs in some cases. Talking about the bypass resistance with MET, there is actually a variety of strategies that are currently ongoing, which include different antibody drug conjugates and different combinations with TKIs, which I will be covering in later slides. And then for histologic transformation, again, chemotherapy with or without immunotherapy, and also continuing perhaps the TKI if there was good response, previously. And then for really the mechanisms where the unknown mechanism of resistance, we have different antibody drug conjugates, as well as chemotherapy, immunotherapy, and perhaps anti-VEGF combination that I will also discuss as another potential strategy for overcoming resistance to osimertinib. So first, focusing on the on-target resistance. So this figure really demonstrates the IC50, which is the inhibitory concentration where 50% of the cells, the tumor cells, are killed in vivo studies. And what we see with the red is where we need a lot of drug to kill the tumor, compared to the green where we need a little bit less of the drug, which perhaps means that these mutations are sensitive to these drugs in green more than the ones in red. And so what we see here, that when we talk about the C797S mutations and maybe compound mutations with T790M and C797S, that osimertinib doesn't really do a good job of killing the tumor cells. But when we compare it to the next generation, 4th generation TKIs, we see some greens here, essentially showing that these drugs, these mutations are sensitive to these drugs, and so this is potentially a strategy. You do see here that some of these studies have shown that gefitinib may be able to act on these mutations like C797S. However, if there is a T790M co-mutation present really here, then it wouldn't be an effective strategy. So there are a variety of these strategies, especially with the 4th generation EGFR inhibitors that are upcoming and currently in clinical trials. We could also look at TKIs plus EGFR targeting antibodies. There have been studies done in the first line, which have shown some benefit. Perhaps this could be another strategy specifically for on-target resistance, and then the novel antibody-based approaches that I will be discussing in subsequent slides. Here is a list of the clinical trials specifically for these on-target resistance mechanisms and these fourth-generation TKIs, which are currently under study, for different tumor mutations and co-mutations, but specifically for the C797 type of mutation, which are either preclinically being studied or in phase 1 and phase 2 trials. Now, when we talk about overcoming off-target resistance, specifically the bypass mechanism with MET that we talked about, there actually till date have been, these about 5 of these studies that have been reported out only in the last 1 or 2 years. And this, table really kind of summarizes the different treatment strategies. So Osimertinib has been combined with Savolitinib and Tepotinib, which are MET TKIs. It has been combined with an MET antibody drug conjugate. So antibody drug conjugate really being an antibody which targets a surface protein, but then it is linked with a chemotherapy agent. So think of this as a smart chemotherapy where it can enter into the cell and release the chemotherapy so we can truly target the tumor cells. Then there are other strategies with Lazertinib, which is also a third-generation EGFR TKI similar to Osimertinib, but then combining it with a sort of a bispecific antibody called Amivantamab, which targets both EGFR as well as another MET target, so the EGFR MET bispecific antibody. And then there's also another strategy of combining these TKIs antibodies with chemotherapy. As you see, these studies have different sort of biomarker selection criteria based on whether you identify MET amplification or expression, but really the overall response rates you see in terms of the shrinkage of the tumor is really kind of consistent, about 30 to 50%. So these are really emerging as useful strategies in this particular subset of tumors where we have MET amplification as a resistance mechanism. So this is the picture of antibody drug conjugate. Like I mentioned, it's an antibody which is kind of linked through a linker with a cytotoxic payload. And currently, the two antibody drug conjugates, which are used as which are used as strategies, especially when we have unknown mechanisms of resistance, is targeting the antigens called TROP2 and HER3. These are two different antibody drug conjugates, datopotamab deruxtecan and patritumab deruxtecan, and they have been studied in patients harboring these in patients with tumors harboring these oncogene-driven tumors, and you see the overall response rates are in the range of about 30 to 40%. Another strategy, I think, which has emerged, especially since the Empower 150 data were presented, is the use of chemoimmunotherapy with atezolizumab and chemotherapy, but adding an anti-vascular endothelial growth factor agent called bevacizumab. There was another trial recently presented with sintilimab and a biosimilar of bevacizumab along with chemotherapy. It is important to note that these trials were designed for all patients with metastatic non-small cell lung cancer, but did have certain subsets where they included patients who had EGFR-driven metastatic non-small cell lung cancer. And they did end up showing some PFS and overall survival benefit here as well. Although there was slight increase in toxicity. So obviously these are another strategies, specifically when there are no clinical trials available, particularly in an institution. And I think these are valid strategies we need to be discussed with your physician. And there are, again, with this immunotherapy and chemotherapy and anti-VEGF combinations, there are multiple trials that are currently ongoing specifically for, patients who experience resistance. One of them, Checkmate 722, was testing nivolumab and chemotherapy versus nivolumab and ipilimumab and chemotherapy. So dual immunotherapy was recently reported at the ESMO Asia conference to be negative. And so I think we are awaiting studies which are specifically including and incorporating the bevacizumab or anti-VEGF agents, because there seems to be some activity that is offered by these particular addition of these particular agents. And here I'm summarizing some of the strategies that I discussed, fourth generation TKIs, combinations with antibody drug conjugates here, as well as the bevacizumab-based regimens with chemotherapy and immunotherapy. All of these trials are currently ongoing, so I think really it's going to be an exciting time in terms of us figuring out to strategize and target these mechanisms of resistance.